Hi guys, this is a Pharm Review video for exam 3 HPS 3. Just looking at neuropharm for this lecture, starting with intro to neuropharm and then looking at seizure drugs, or anti-seizure drugs rather. And it's not too bad. That said, I would say, maybe watch this on 2 times speed, and then Sketchy has a lot of videos on this, so I would preferably focus on Sketchy. I know that's what I'm going to do after going over the theory here. So basically, starting with neuropharm, we're just going to talk about neurotransmitters and then neuromodulators and the different receptors, and that's pretty much it. And then we'll talk about the anti-seizure drugs as we talk about those receptors as different targets and the different neurotransmitters in this first part. All right, so just starting with the basics, we have the central nervous system. We know is the brain and spinal cord, and we have around 100 billion neurons in the central nervous system. Mostly, they used glutamate as the primary neurotransmitter. This is an excitatory transmitter, but glutamate, drill this into your brain. Glutamate is the primary neurotransmitter for the central nervous system. Then we have, with the exception, motors and preganglionic autonomic neurons are going to use acetylcholine, and then a small number of synapses will use serotonin and purines as neurotransmitters, but for the most part, we're dealing with glutamate as a positive neurotransmitter. We'll see concepts of neuromodulators come up, and some other neurotransmitters, but glutamate, overall, main transmitter. All right, the release of neurotransmitters at excitatory synapses is going to activate ionotropic receptors on the postsynaptic cell, right, its target. And then we had an example of just an action potential. So this is not glutamate, but just going back to the basics. What did we learn way back in MSK? Talking about motor neurons of muscles, you have acetylcholine released into the synapse to trigger the action potential on the muscle fibers. And so when you have an action potential on the neuron, you have many vesicles of this acetylcholine being released. But in the central nervous system, you are not going to have so many vesicles of neurotransmitter release like you do peripherally in the synapses with muscle. So the difference, though, you're going to have less vesicles, but you're also going to have more presynaptic activity to trigger the action potential. So more neurons firing on a single neuron to get them to trigger an action potential overall. All right. So in the central nervous system, when we're talking about these ionotropic receptors, again, these are going to be mostly at our excitatory synapses, but let's just talk a tiny bit more about ionotropic receptors in general, what they are. They're ion channels that are opened by neurotransmitters, and so they're ligand-gated channels. Something binds to it and it goes ahead and opens. These ionotropic receptors are closed at rest, but open when the ligand, or in this case, ligand being general term, neurotransmitter, binds. Excitatory synaptic transmission is going to be done, and it drives cations, potassium and sodium, through them, with a net sodium going inwards to depolarize the cell. And then neurotransmitters just generally linger very briefly in synaptic clefts. So receptors are only open very briefly. And here is just an example. We have some neurotransmitters being released after an action potential, and then that's binding to these ionotropic receptors and letting sodium in, and then you have an action potential, a depolarization on the postsynaptic cell, or the target cell. All right, then you have the idea that these ionotropic receptors are ion channels, overall ligand-gated ion channels, but you actually have different families of them, and so basically, most of these are of the cis loop protein family, which you can see here. These are supposed to be like the cis loop ones, but you have different subunits that make them specialized for each neurotransmitter. And so here you can see, ones for acetylcholine, GABA, which we'll talk about as sort of an inhibitory neurotransmitter. But GABA stands for gamma aminobutyric acid, and then glycine, another neurotransmitter. And then you have glutamate, channels, and remember glutamate is our primary neurotransmitter in the central nervous system, and then we have ATP receptor channels. But notice how they all just sort of differ in their subunits, but acetylcholine and GABA are very similar. So if glutamate's the one that we are using mostly in the central nervous system, let's talk a little bit more about that. There's three main classes of glutamate receptors, GLU-A, GLU-N, GLU-K, and again, you're just going to have them be used for slightly different things, but glutamate A receptors are going to permeate the cations, K plus and N plus. Again, remember these are ligand-gated ionotropic, so basically what we're saying is ligand binds, glutamate binds. For GLUT-A, sodium's going to go in, potassium's going to go out. All right, and then another one is GLUT-N. GLUT-N is also going to permeate cations, potassium and sodium, but it can also do calcium. GLUT-N, though, as we can see here, you have the neurotransmitter binds, but it can actually get blocked by magnesium. And so GLUT-N receptors can get blocked by magnesium. So even if its glutamate is bound to it, no action potential can occur. And then, yeah, so basically you have magnesium, and you can see that it's bound to the receptor, and so no action potential could get, or no cations could get through that. We were told in lecture that these glutamate N receptors can still conduct with magnesium bound, but only if the cell is already depolarized. All right, hopefully that's a fact we don't need to know too much about. But we have these different receptors for glutamate, and then we were told something which is fairly cool, which is, so GLUT-A and GLUT-N are kind of work together in this idea of long-term potentiation. So long-term potentiation just like reinforce certain synapses between neurons such that that pathway can be used over again or more easily, such as, say, learning something. So GLUT-N will only allow ions to go through if there's a strong depolarization. And then, so in this case, calcium through glutamate N receptor will only occur when the action potential has occurred. But the idea is that it will activate something called calcium calmodulin protein kinase 2, and that's going to signal the insertion of the glutamate A receptors into the membrane. And so the idea is that this potentiates the synapse, aka making it stronger and easier to use again, and easier for action potentials to occur, because now you have GLUT-A inserted into the membrane, which isn't going to be blocked by potassium, and it basically just allows learning and memory to occur by strengthening synaptic connections. All right, so we talked a little bit about ionotropic receptors, and they're going to do stimulatory work by having neurotransmitter bind to them. Glutamate is our primary neurotransmitter in the central nervous system that's doing excitatory work. And then we have GLU-A and GLU-N receptors. We also have GLU-K, but A and N are the ones we care about, and N can get blocked by magnesium. So now it's time to talk about sort of the opposite of excitatory, which is inhibitory. So we have inhibitory synapses of the central nervous system. And so inhibitory neurons are going to dampen excitation. And these neurons project axons to shape the function of the neurons around them. And so they're going to be using, we already kind of mentioned it, but the neurotransmitter GABA. And so GABA is using GABA ionotropic receptors. And so GABA will bind, and then chlorine in particular will go in. And so you're going to make the inside of the cell even more negative, and it's going to be harder for the cell to depolarize. So GABA A receptors let chlorine into the cell, and neurons are going to have to use ATP to pump chlorine out of the cell. So GABA allowing chlorine ions into the cell is going to result in hyperpolarization. This is going to inhibit the neurons and counter the excitatory inputs overall. All right, so GABA is going to inhibit, is an inhibitory neurotransmitter. Glutamate is a stimulatory neurotransmitter. All right, so then we have this idea that in addition to the ionotropic ion channels used by glutamate and GABA, you have metabotropic receptors in addition. And so the neurotransmitters that use metabotropic receptors, which are generally heptahelical or G-coupled protein receptors, are normally neuromodulators. And we're going to get a good example of this with dopamine in our neuro course. But basically, they these neuromodulators don't signal excitations or inhibitions, but instead how they function. Instead, they influence sort of neuronal circuits. And the best known neuromodulators are dopamine, histamine, acetylcholine, opioid peptides, leptin with hunger. But dopamine and neuroepi, dopamine is going to be the big one we talk about in class. We have the substantia nigra of the basal ganglia, and then it's going to help modulate these motor pathways for arm, like limb movement, trunk movement, etc. All right, so co-transmission. So many times a neuromodulator is released at the same time as glutamate or GABA, and so we have the metatropic receptors that these neuromodulators can act on, but in many cases these metabotropic receptors can also accept glutamate or GABA, and so you can have glutamate or GABA activate their receptors, but then also activate metabotropic modulator receptors. So GABA and glutamate activate their receptors, and they can activate the metatropic, or you can have GABA and glutamate activate their ionotropic receptors, and the neuromodulator can activate their metabotropic receptor at the same time. So, how is the signaling occurring? Just think our metabotropic is binding. It's a G-coupled protein pathway. So you have GDP, GTP exchange, and then you're going to have the alpha and beta subunit of the receptor dissociate and then go to its protein target, or to its targets throughout the cell, change expression of different proteins, etc. But most neuromodulators can act on different receptors. The example is neuroepinephrine, which can act on multiple G-coupled protein receptors that we're familiar with from class. So we're almost done with this particular lecture, but neuromodulators, just a tiny bit more. An example of ionotropic receptors causing a fast depolarization. So think like acetylcholine causing fast depolarization on a nicotinic channel, but then you also have so acetylcholine binding to an ionotropic receptor. You have a fast depolarization, but then you also have a the neuromodulator is also a metabotropic receptor is being stimulated, and so acetylcholine in this case can act on that as a neuromodulator for its own circuit, and then that is going to result in a G-coupled protein pathway that's going to open a K channel, and this is going to, so if this direction is depolarizing the cell, basically cause a slow depolarization that's going to make it easier for the cell to depolarize in the future. So just an example of neuromodulating, make it easier to depolarize overall. All right, so that was it for that particular lecture. Then we had more on these ion channels and ionotropic receptors in the form of talking about seizures as targets. So we'll get into that. There's a bunch of different pathways. We'll talk about 4 different methods of dealing with seizures. And I just want to point out that Sketchy has great videos for these. And as I said at the beginning, I'm going to be using Sketchy myself after, we look at the theory here. So, all right, so just a quick thing on, we talked about seizures, but really what we're focused on is the condition of epilepsy. And epilepsy is defined by recurrent seizures, and that is abnormal electrical activity in the central nervous system and its clinical manifestations. About 1%, so 1 out of every 100 people has epilepsy. It's the most common neurological disorder after stroke, and it can have a genetic basis or result secondary to like damage, trauma, stroke, tumor, neurodegenerative disease. But you have 2 classifications of our so epilepsy is characterized as recurrent seizures. So 2 classifications of seizures. You have focal seizures, which are located to a patch of cortex, and its symptoms depend on like the type, like where the area of cortex it's affecting, and then you also have primary generalized seizures, and so focal seizures just located to a particular part of the cortex. Primary generalized seizures are going to have something to do with the thalamus, and the thalamus is our relay station, right? So something wrong with the thalamus, very not good. All right, so then the pharmacology of epileptic seizures. Standard drug therapy is only control about 2/3 of patients, which is not great, but it's important to know that the available drugs are anti-seizure, and we'll see as anti-seizure drug, ASD, not anti-epileptic. and the most common one is gabapentin, which we'll talk about. But GABA is inhibitory, so the overall strategy for these drugs is to reduce the excitability of the the brain, which is unfortunate. So with less action potential, you're going to have less abnormal action potentials, right? So that's a little bit scary though, because your brain, right, needs the action potentials to just function. So the idea is like, how can you do this in a way that helps with seizures but doesn't like screw up your functioning? So if you can just reduce the excitability, not eliminate the excitability, that's the goal. So we have 4 different mechanisms, and they all have to do with neurotransmitters to some extent. So the first mechanism, and again, the goal is to reduce network excitability for all 4 of these mechanisms, is to modulate cation channels, so sodium, potassium, calcium. If we want to reduce excitability, we want to keep action potentials from occurring so easily. So first method of modulating cation channels, right, these ionotropic channels, is to prolong the inactivation state of sodium channels, increase the throughput of potassium channels, and then inhibit calcium channels, right? Make it harder for calcium channels to work such that you can't depolarize as easily. So make depolarization harder. That's our goal here for the first strategy. The second strategy is to enhance GABA transmission. We know GABA is inhibitory, so let's make our receptors like act on those, keep GABA from being broken down, keep GABA from being reuptake. Could we just use like a synthetic GABA? But inhibit action potentials. The next is modulating synaptic release. So if you have GABA being stored in synapses, can we get more of that? Can we release more GABA? That would be cool. And then diminish synaptic excitation mediated by glutamate receptors. So if glutamate's stimulatory, excitatory, could we diminish the activity of those slightly? These are our overall targets for dealing with overexcitability, abnormal brain activity that you see in seizures. All right, so our first strategy, and I've marked these all with like 1, 2, or 3 for 1, 2, 3, and 4. Excuse me. All right, so if we want to modulate the ion channels to like lower action potentials, we know that sodium going into the cell is going to depolarize it. So basically, we have our action potentials are mediated by voltage-dependent sodium channels, and they open in response to supra-threshold depolarizations, which allow sodium into the cell, and it leads to upstrip of the action potentials. After it's opened, it's going to inactivate, which leads to decay of the action potential and enters a refractory state. So can we make sure that the sodium channel stays deactivated or inactivated for slightly longer, such that you have less action potentials overall? And we have a number of drugs that do this. The first is carbazepine, and then phenyltoin, and then lamotrigine. And those are thought to make it easier to do sodium ion channel inactivation. And this result is a suppression of high-frequency spiking that would constitute a seizure while sparing regular neuronal activity. So lower frequency of action potential firing, but carbazepine, phenyltoin, and lamotrigine act on the sodium channels to keep them, make it easier to inactivate them. All right, the second step is trying to inhibit calcium channels. And specifically, you have these low-threshold T-type calcium channels that are important for firing in the thalamus. So our example drug is ethosuximide, and ethosuximide is used in the treatment of generalized absence seizures. So these ones that have to do with the thalamus versus focal, which are specific areas of the cortex. The thalamus can affect everywhere because it's the relay station. Ethosuximide is going to block the T-type calcium channels, and as a result, help inhibit action potentials. So less action potentials, less seizures. All right, then you have potassium channel excitation. So unfortunately, we don't have any common use potassium channel targeting drugs, but basically potassium channels are a molecularly diverse group of channels that dampen neuronal excitation. We did have an uncommon one called retijabine, also known as ezogabine, increases the activity of potassium channels, and unfortunately it's not used anymore not used in the US anymore due to retinal toxicity. All right, so then we're almost done. Second strategy, other than reducing action potentials via reducing depolarization, is to increase or inhibitory neurotransmitters, so increase GABA. So how can we go about do that? Well, we're going to use benzodiazepines. And so we have GABA is an inhibitory neurotransmitter released by neurons. It inhibits action potentials by allowing chlorine into the cell. It acts on ionotropic as well as neuromodulator receptors, the metabotropic receptors. Barbiturates, pentobarbital are effective ways of acting inhibitorily. Inhibitory. They are sedatives. They enhance the activity of GABA overall, and they're rarely used. But anyways, we have benzodiazepine, and you have your benzodiazepines, clonazepam, lorazepam, and diazepam are going to increase GABA-induced chlorine ion influx into the cell by acting as allosteric modifiers on GABA channels. So allosteric modifiers increase GABA binding, so increase chlorine into the cell. All right. So continuing with this idea of, as we see it too here, modulating or enhancing GABA's effect. Looking at GABA receptors in particular, they're heteropentamers made up of alpha, beta, and gamma or delta subunits, and the subunits allow for drug specificity. The benzodiazepines, remember these guys right here, clonazepam, lorazepam, diazepam, they act on GABA A receptors that have gamma and alpha subunits only, but you have basically, just knowing that GABA receptors have different subunits, alpha and gamma are what benzodiazepines work on. If you can increase the amount of GABA, that could work as well. So basically we have the idea that GABA gets recaptured by GABA transporters on neurons and astrocytes. So we have two drugs, tiajabine inhibits GABA reuptake, and then vigabatrin blocks GABA metabolism for breakdown. All right. So then finally, we also have GABA analogs that were developed across the blood-brain barrier. We have gabapentin and pregabalin, both very effective anti-seizure drugs, but they're actually inactive at GABA A receptors, and they have high affinity for a subunit of a calcium channel, so it helps to depolarize the cell, and the net result is inhibitory, just like regular GABA. But gabapentin and pregabalin actually don't work on GABA receptors, despite the fact that they are GABA analogs, which is maybe a potential question. All right, then we have a potential quiz question. Synaptic vesicle release. The anti-seizure drug levetiracetam targets the synaptic vesicle protein SV2A, which are vesicles that contain GABA. How it works is a little unclear, but the basic idea is that you're going to encourage GABA release into the synapse to do its inhibitory effects. All right, and then finally, we said glutamate is the primary excitatory neurotransmitter in the brain. We have an antagonist for glutamate since it's excitatory. GABA is inhibitory, and we want inhibitory stuff for seizures. So we have perampinol is a non-competitive antagonist of glutamate A receptors. So it reduces synaptic transition, aka reduces action potentials. Unfortunately, it's a very narrow therapeutic window, but it can help suppress development of seizures. So that's about it. Then we have valproic acid and topiramate. These are widely used and effective anti-seizure drugs, but they have a poorly understood mechanism of action. So valproic acid, good against focal seizures and generalized tonic-clonic combination seizures, also used to treat bipolar disorder and migraine. Broad spectrum, presumably related to multiple targets. And then topiramate, discovered by phenotypic assessment, but effective against focal and generalized tonic-clonic seizures, used to treat migraines as well. Likely has multiple targets: sodium channel, GABA, and then glutamate receptors. All right, and then finally, disease-specific anti-seizure drugs. Different diseases can have an underlying genetic mutation. So example is we have the drug everolimus, is an mTOR inhibitor for epilepsy. And then we also have fenfluramide is a serotonin releaser, and then cannabidiol are used for these particular syndromes, Dravet and Lennox-Gastaut syndromes, Lennox-Gastaut development delays, jerking of muscle, other seizures, difficulty sleeping, febrile seizures, orthopedic issues, decreased growth and nutrition. So fluoramide releases serotonin, and then cannabidiol helps with Dravet and then Lennox-Gastaut disease, but seizures in childhood, developmental delay, abnormal EEG characteristics. All right, we're just about done. So adverse effects, we have lots of them, but this is all dealing with inhibiting the action potential. So therefore, central nervous system depression, so sedation, drowsiness, fatigue, impaired cognition. We have this huge list here, and I don't think that we need to know them other than just knowing central nervous system depression. But just take a look: sedation, tolerance, dependence, lethargy, headache. Yeah, there's just an absolute enormous number. And then just beyond epilepsy, anti-seizure drugs are used for multiple conditions: neuropathic pain, psychiatric disorder, gabapentin and pregabalin. Remember, those are GABA analogs. They're effective for treatment of post-therapeutic neuralgia, diabetic neuropathy, fibromyalgia, and then valproic acid and topiramate can be used for the prevention of migraine. All right, so that's it, and at least for those 2 lectures. Good job, guys, and again, I think Sketchy is a good resource here, but hope you guys are doing well and not stressing too much. All right.